If sleep is the foundation of health, then few have done more to reshape how we think about that foundation than our next speaker. It's a pleasure to introduce Dr. Colin Espie, professor of sleep medicine at the University of Oxford, whose work has challenged us to rethink chronic insomnia, not just as a symptom, but a condition deserving precise, scalable, and patient-centered care. From pioneering behavioral treatments to advancing digital therapeutics, his contributions have consistently pushed the field forward in a thoughtful and innovative ways. We're truly fortunate to have him here to help us reimagine insomnia care in the 21st century. Please join me in welcoming Dr. Espie.
Hello, everyone. It's great to be with you. I'm Colin Espie. I'm the professor of sleep medicine at the University of Oxford. And as you can see on this header here, by training, I'm a clinical psychologist, and I've been involved in sleep research for quite some time. Saw my first insomnia patient in 1980, I believe, when I qualified clinically. I work as a professor of sleep medicine at the University of Oxford. I really wish this was our sleep lab here. It's actually just one of Oxford's beautiful buildings. If you haven't been before, do come and visit us at some point. You see, I'm in the Nuffield Department of Clinical Neuroscience, and in that setting, I founded the Experimental and Clinical Research Centre, and I'm also the clinical director of sleep medicine training. So it's lovely to be with you, and I'm so happy that your course is comprehensive and is covering this very, very common sleep disorder that we call insomnia. It's not a new problem. It's been around for a long time. And I want to maybe just give you a little bit of a helicopter view of where we're at the moment with the care for people with chronic insomnia. So by way of conflicts, I have obviously got research support from a variety of sources here. Also authorship of a number of books, one of which I will mention because I hope it's relevant to you. And I'm also the co-founder of a company called Big Health, which developed a digital cognitive behavioral therapy called Sleepio. I'm going to mention that here, but in the context of just the general way in which we're trying to develop services for people with insomnia, and I will mention other products as well. So there have always been two ways of addressing insomnia because it's not a new problem. So this fellow here is Dr. Robert McNish, a Scotsman, and he wrote in this book, The Philosophy of Sleep, in some cases of restlessness, sleep may be procured by the person getting up and walking for a few minutes about the room. It's not easy to explain on what principle this acts, but it is certain that by such means, sleep sometimes follows where previously it had been solicited in vain. What is this telling us? This is a behavioral intervention for insomnia from the 1830s. What it tells us is, although that in that era there may not have been scientific experiments conducted, there were observations that behavioral interventions could make a difference to your sleep. So that's one way of addressing insomnia, through what we do. But there have also been pharmacological interventions. And here we can see an explanation from Professor John Buckley Bradbury in Cambridge University, explaining that the reason for insomnia is the cerebral cells have assumed a condition where it's necessary that activity to bring them back to a more natural state. In other words, you've got to down-regulate the brain's arousal system. And this is where hypnotics, he says, are of such great value. Now, I'm sure back in those days, there weren't randomized controlled trials done of chloral hydrate or even anesthetic compounds, nor were there of behavioral interventions, but there have always been two ways of addressing insomnia. And there still are. We have medication, pharmacotherapy. There's a formulary of medications which can be used to manage insomnia, and it has multiple transporter systems. But there's also this thing that I've called here CBTx, which stands for Cognitive and Behavioral Therapeutics. You probably have heard of CBT, but perhaps what you haven't heard is CBT is not a treatment. CBT is a family of treatments with many different components, and it utilizes cognitive and behavioral therapeutics, helps people address their racing mind, helps them to get their behavior back into a regular pattern again, and again uses multiple transporter systems. So I'm going to explain more about that as we go on. But if we think a little bit here, first of all, about pharmacotherapy, here's the drugs that have been available. When I started my clinical work, there were also barbiturates. People were still on barbiturates for chronic insomnia problems. Then the benzodiazepines came along, and then the benzodiazepine receptor agonists came along. And as you can see, there's a family of drugs there. Zopiclone, Zolpidem, Zaloplon, Isoprolol, as they're originally known as compounds. So the treatment of insomnia is by pharmacotherapy, using a class of drugs, using a specific drug in a particular transporter system, which is usually oral medication. There are melatonin receptor agonists, and there are dual orexin receptor antagonists, which target the orexin system and block the binding of weight-promoting receptors and suppress the wake drive. And there's different ones of those as well available, and varies across the world which drugs are actually available to treat insomnia. My point is really that we have a formulary of treatments. And one of the main things I want you to take from today is that we have a therapeutic formulae also of cognitive and behavioral therapeutics. And this is a book that I brought out last year. It explains this whole way of thinking about CBT as an intervention for insomnia, but importantly, is a guide to actually how you go about delivering cognitive and behavioral therapeutics. Just as an illustration of that, if you look at the kind of treatments that are cognitive and behavioral therapies that are mentioned in the European guideline and in the most recent ASM guideline, certainly the family name is used, like cognitive behavioral therapy, and there's abbreviations of that therapy on the behavioral side, which is called a brief behavioral therapy. But these are just some of the other names that you will come across. And I'm mentioning them here because there's not really scope within the context of this lecture to train you in all these different techniques. But you might say that Dr. Robert McNish's suggestion of getting out of bed and walking around when you can't sleep is a form of stimulus control therapy, which is an evidence-based treatment approach within the CBTx framework. Because sleep restriction therapy is about re-establishing a strong connection between the bed and rapid sleep onset. And obviously, one of the difficulties that arises where people have insomnia is that they have a connection between staying awake and being in bed, not being able to get to sleep, waking up in the bed, but importantly, not being able to get back to sleep. So the connection there is bed wake, not bed sleep. And stimulus control therapy is about re-establishing the bed sleep connection. It's kind of what you do with your children as you train them through a habit training protocol to get into a sequence of behaviors that involve falling asleep. You right on your side now, lie on your side. I'll put the light out. See you in the morning. But prior to that, you've had you've got them ready for bed, or they've got themselves ready for bed. You've read them a story. You've patted them. You've given them a little kiss. You've reassured them. That's all a stimulus control pattern. Sleep restriction therapy involves reducing the amount of time that you spend in bed at night to be more equivalent to the amount of time you're actually sleeping. And this increases sleep pressure and helps entrain circadian rhythm again. In some of the work that we've done, we found that over a course of sleep restriction therapy, you can sometimes be reducing actual sleep, objective sleep, by 8 to 10 hours a week. Because the purpose of this is really, this behavioral intervention is designed to prime the homeostat. And it maybe tells you something important about cognitive and behavioral therapeutics, that this isn't a binary thing, that pharmacotherapy is biological and psychological therapy is psychological, that many of the psychological therapies operate through habit retraining and through biological mechanisms, like priming the sleep homeostat. Relaxation training, reducing arousal levels, learning techniques to reduce physiological and cognitive arousal. Biofeedback's connected to that, in that it's really about using feedback from the bodily system to be able to demonstrate you're able to reduce muscle tone. Paradoxical intention is about learning not to try to sleep. That a good sleeper is not good at sleeping, but they're actually almost like just falling asleep. I've never met anyone who can get to sleep. I've only met people who can fall asleep. And one of the paradoxes in insomnia is that the harder you try to get to sleep, the more likely you are to render yourself awake. And paradox is a kind of reverse psychology approach to managing that. Intensive sleep retraining is more a lab-based protocol to get people back into a good sleep pattern, but it's a behavioral protocol. And mindfulness and ACT are third wave therapies, which are really to do with being able to have a better relationship with your sleep and your insomnia, and being able to let go around all those things. I mentioned sleep hygiene in the middle, and we'll come back to that right at the end when I've got a little animation to show you, because I've got a bit of an update for you on sleep hygiene, but it's not an effective treatment in its own right. There have been 4 enormous changes in the insomnia landscape over recent years. The first of these has been the recognition that insomnia is a disorder in its own right, and it should be actively treated whenever it presents, including alongside comorbid conditions like depression or diabetes or chronic pain. It used to be thought that we should treat what we've thought to be the primary problem. Oh, you're depressed, so therefore if we treat your depression, your insomnia will improve. Unfortunately, that generally wasn't evidence-based. Insomnia was often there before the depression and was part of the incubation of the depression, and often persisted after depression. Other depressive symptoms were eliminated. The DSM-5, which came out in 2013, was the beginning of recognition of insomnia as a disorder in its own right. And in 2014, I published this sleep condition indicator based on DSM-5 criteria. And basically, the core of that is that you need to have difficulty sleeping 3 or more nights per week. You see this individual here is indicating 4 nights per week, 3 or 4 nights per week. And you need to have had that difficulty, for at least 3 to 6 months. So you get difficulties initiating, maintaining sleep that are present for 3 or more nights per week, there for at least 3 months, and that's affecting you during the day. And this is a simple measure with a 2-item short form. How many nights per week are you having difficulty sleeping? And how much is your sleep, to what extent has the sleep problem been troubling you? So this is a useful scale for use in everyday practice. And the right-hand side, as you can see, the grayed out area, it helps you to see where the symptoms of insomnia may lie for your patient. Secondly, another enormous change in the landscape has been that the guidelines for insomnia management, for chronic insomnia management, are consistently now that CBT is the best evidence treatment, and that CBT should be first-line clinical care for insomnia. And these are some of the guidelines that have emerged over the years. The first one, perhaps 1999, the American Academy of Sleep Medicine guideline. And interestingly, when you were in this area, 1999, 2005, 6, the term CBT wasn't invented. In fact, these 99 guidelines talked about non-pharmacological treatment for insomnia. That, if you like, the CBT approach was defined as what it's not. It's not a drug treatment, because this was a change in the landscape, if that's making sense. And we go through these various guidelines: American Academy of Sleep Medicine again, British Association for Psychopharmacology, American College of Physicians, European Sleep Research Society, the BAP update, the ASM update, the ESRS update. And what they have shown us is that the evidence base is that cognitive and behavioral therapies are better treatments for achieving longer-term sustained outcomes with insomnia. Now, you probably don't know too much about the background to cognitive behavioral therapy, and it's based on psychological theories that have been developed over a number of years. So I suggest that this might be a good reference point for you, because this psychobiological inhibition model, which I developed around 2000, was really an overarching model to try and take account of all the thinking that had gone into the development of cognitive and behavioral therapeutics. And it was updated just a couple of years ago. So that paper may give you a lot of the background about how psychological principles in practice have come to develop treatments that have then come to become the guideline approach for managing insomnia. Thirdly, there's evidence that treating insomnia effectively may alleviate comorbid mental and physical conditions. A lot of the trials that we do nowadays using CBT approaches for insomnia don't have sleep or insomnia as the primary outcome, because there's so much evidence that you can improve the symptom complaint and the syndrome that is insomnia, and that you get remission of the insomnia with the treatment. The reason for this being that the person is then able to sleep more naturally again, because you've re-established the setting conditions for sleep to happen in the first place. I think that's why you get lasting benefit from it. So the studies that we're often doing nowadays are looking at other outcomes, like is CBT for insomnia, does it improve mental health symptoms? Does it improve workplace productivity? Does it improve metabolic health, and so on? And there's a developing evidence base that this is the case. Now, why so? Well, if you think about the roles and functions that sleep serves in our lives, that sleep could be regarded as nature's medicine, really. It's what evolution has provided as our nightly treatment in order to function, or even to be awake, and to function cognitively, emotionally, and physically during the daytime. It's sleep that restores our health and well-being. And nature has decreed that as human beings, we need rather a lot of sleep. We could argue about the amount you need. It's probably a normal distribution, with people needing their own particular amount of sleep, some being longer or shorter sleepers. But getting the amount of sleep that you need gives you the amount of treatment that you need through sleep medicine at night, if that makes sense. So this is perhaps why, if we get sleep correctly timed, and I think circadian aspects are really important, as well as the amount of sleep we need. If we get that on a regular basis, and it's happening kind of naturally for us because we're not even having to think about it, then that is our best chance of health during the day. So therefore, if people have got impaired sleep through whatever sleep disorder, insomnia, sleep apnea, restless leg syndrome, etc., then there are consequentials to that which should be improved with effective treatment. And there's evidence of that emerged as another big change in the landscape in recent years. And just to illustrate that comorbidity is a norm, not the exception, here's a randomized trial that we published 2019. But I show you this because it's a large randomized trial. There were 1,771 patients randomized in this study. But you can see that 2/3 of the population had at least one other comorbidity. And the mean age of the sample was 48, which is quite typical of insomnia studies. So it's a norm for people to have other conditions, and they should be treated, but so should the insomnia. That's what the guidelines tell us nowadays. Now, I mentioned about different transporter systems, and what we're used to, of course, with medication is that's an oral tablet. With psychological therapies, with CBT-I, the standard approach is to deliver CBT through in-person care, and this can be delivered by a range of healthcare providers suitably qualified. And I would draw your attention to this kind of debate that appeared in May 2025 in the journal Sleep, looking at the pros and cons of that. Who can safely and effectively deliver CBT? What level of training do you need, etc., etc. It's a useful article, and this is a table from it. And I think the evidence is that there's a diverse range of professionals who can deliver CBT per protocol. And if you think about it, all healthcare systems require both generalists and specialists to meet population need. So it would be great if everyone knew more about insomnia, everyone knew more about the assessment and treatment of insomnia. And when I say everyone, I mean people who've got an interface with patient care, who're working in health services. You want journalists to know enough to be able to do some basic intervention, I think. And you need specialists also, in addition to that, to help with more complex cases. So, who may deliver CBT is really a generic matter of clinical governance, as long as people are suitably qualified and registered, have the credentials, expertise that are in the public domain and are open to scrutiny. Professionals need to operate obviously within the limits of their qualifications and expertise, and there are licensing bodies and training bodies which are involved in this. I mention all this for two reasons. One, I think it's important that we socialize cognitive behavioral therapy. It's not just delivered by behavioral sleep medicine experts, that it's something that's part of our armamentarium as clinicians generally. And that's necessary and normal in healthcare. But I also mention it because we need to socialize it within a clinical governance model. We don't want, and we shouldn't have, just anyone setting themselves up as a sleep expert because they've read a book on how you manage insomnia. It's an important condition. It's a serious condition. It confers risk for the development of psychiatric and other disorders, and it needs to be correctly managed within the context of a registered healthcare provider system and so on. Models like step care, which is mentioned down here, are ways of efficiently managing populations of patients. And this is what happens, if you like, in healthcare generally, that you have generalists and specialists. And if the generalist, your primary care physician, for example, feels I need more help with this, then he or she will send that person to a specialist. And it makes it efficient use of skill mix and expertise, and ensures best treatment and best practice. So that paper, those two papers, that debate about who can deliver cognitive and behavioral therapy, I think is interesting, and I would commend it to you. It's in the journal Sleep. But there's a big gap in meeting insomnia guideline care, because you think about, well, cognitive behavioral therapy is the guideline treatment of first choice, but hardly anyone gets access to cognitive behavioral therapy quickly in the way you could do with a medication by seeing your physician on a particular day. You could have in your hand a sleep solution to take that night. Plus, the number of people who get access to cognitive and behavioral therapy compared with pharmacotherapy is rather small. I don't know what the actual ratio is, but I would have thought there'd be 1,000 people would get medication first or only, compared with the one person who gets CBT when you think at the national level. So the gap in meeting this insomnia guideline care would really mean that you should have a one-to-one availability, so that the CBT could be offered prior to medication. That's what the guidelines would suggest. At least people should have choice. So how do we solve the gap in meeting that a lack of availability? And I think that gap in provision of cognitive and behavioral therapeutics is currently bridged by pharmacotherapy, which is great. And I'm not in any way, shape, or form against pharmacotherapy. I'm pro evidence-based treatment. I'm very grateful that we have drugs that are safe and effective that can be used when people don't have access to CBT. But we need to try and think how we can solve the gap. And that's where this last change the landscape, I think, comes in, that there is now regulatory clearance of digital cognitive behavioral therapy products that make guideline treatment possible at population scale. And that's a fairly recent phenomenon in the last year or two. So what is the fundamental reason for CBT not being available compared with medication? I think these things on this list are often regarded as this is the problem we're trying to solve. That cultural practices reinforce medical management. That's why there's so many pills prescribed for insomnia. That practitioners are overprescribing. That the drug industry is aggressively marketing their drugs. The patients want a quick fix. That CBT in any case is too hard. That there's a lack of clinicians and therapists to deliver CBT, and that we don't have efficient enough step care models. And if we did, things would be solved. And if we had more money went into psychological care, then CBT would become available and the drugs would take their place alongside or as second line treatment. Now, there's truth in some of these points, but I don't think that these are the fundamental reasons for CBT not being available at scale. You could train thousands of people to deliver CBT, and you still wouldn't be able to deliver it at the scale that's required for a problem that is, affecting 10 to 12% of the population on a chronic basis. So important things to address, but not the fundamental reasons. And I think here we should look back at the transporter systems that we generally use. Now, these are all ways in which drugs may be administered. They be administered, as injection form, intravenously, intramuscularly, under the tongue, nasally, etc., etc. And of course, as pills. CBT may be administered by several routes. You could see people individually with insomnia. You could see them in groups of 4 or 6. You could have a group of 20 or 40 or 100, a classroom effect. You could be more efficient, perhaps, by seeing people in any of these modes using teletherapy, text, phone, online. Bibliotherapy is, I suppose, evidence-based written material, which is probably a little bit old school nowadays. And you can enhance your in-person therapeutics using digital tools that help people to complete a diary online or give them information where it reinforces their behavior, what they're doing at home, and put some of the modules into an app or whatever. However, it's only really oral medication that is scalable. The reason we're able to treat common problems like insomnia and depression, for example, at population level is because we don't have to bring them into the clinic to inject them. That what we're doing, in fact, is giving them a self-administered treatment at home. We're recommending it, prescribing it, explaining about it, asking them, go and do that yourself according in the ways that I've suggested to you. Now, fully automated digital CBT is cognitive behavioral therapy in an evidence-based application, web or app, or both, where you don't actually see the clinician at all. You get this on recommendation from your clinician, in the same way as you get this on recommendation from your clinician. You collect it and you work on it on your own. You collect it and you swallow it on your own. Now that is really a new approach altogether. And there may be others that will come. And I've mentioned and emphasized the importance of evidence and governance. So, some of these things are kind of very exploratory at this point, but there is an evidence base for fully automated digital CBT, and our products are regulated by the FDA, and I'll mention that shortly. So I think it's only fully automated software as a medical device, SAMD, that's the term that's often used. Sometimes it's digital CBT, sometimes it's software as a medical device, sometimes it's digital mental health treatment. There's various terms being used. But my point is that the fundamental reason why we can't deliver evidence-based care for insomnia at population scale is that CBT has not been made available to them. And that would have been true with drugs as well if you hadn't had oral medication. It's only these kinds of transporter routes that are scalable because they are self-administered. Now, there's a couple of articles I'm going to draw to your attention. This is one that I wrote with John Torres from Harvard and Troy Brennan from CVS Caremark Health. He was his chief medical officer, emphasizing the importance that these digital therapeutics, these digital mental health treatments, should be regulated with gold standard evidence. That's really, really crucial. And that means clinical trials, placebo-controlled trials, ideally to start with, and trial. And between the two regulated products under FDA have had between them somewhere around 150 clinical studies now, and between them somewhere around 35 randomized controlled trials. Really, really important. And these treatments should not be made available until they're evidence-based. It's not about building an app and sending it to people. It's building an intervention, testing it, getting it regulated, and making it available, just as you would do with drugs. Another paper in World Psychiatry really emphasizes that being evidence-informed is not enough, that digital therapeutics, digital CBT, software as a medical device in this form needs also to be evidence-based. In other words, you can't say, CBT for insomnia is effective. This product contains CBT for insomnia, therefore this product is effective. We don't get to do that with people's health. We have to demonstrate per product, if it's making medical claims that it's treating a condition, that this product itself is safe and effective. Digital mental health treatments are a new treatment class defined by CMS. They must be FDA cleared under this guidance. And FDA reviews, assesses clinical evidence, software quality, and cybersecurity, just as the FDA would do with other things. But it's a new class of treatment, and it can include both patient-facing interventions and provider dashboards that provide insights. Here we're talking about interventions designed to treat a condition, and they can be prescribed by both traditional and non-traditional licensed prescribers. And this is quite important, that that these new products, you can be as a licensed a professional can prescribe them, not just a medical professional. So it could be a clinical psychologist, a licensed clinical social worker, and so on. And I think this is important because we've already demonstrated how common insomnia is as a disorder, and that often the interventions we've conducted have involved other professionals, not just, say, clinical psychologists. And that's why that debate that I mentioned earlier on in the journal Sleep is so important to reflect upon. So these, to date, there are 2 digital CBT treatments for insomnia that have been cleared. Sleepio RX, which is produced by Big Health, which is the company that I co-founded, and Somryst, which is distributed by Knox Medical. These 2 products are treatments that have been reviewed and cleared by the FDA, and these are the terms here. And you can see RX only available for use by clinicians and patients today. At the moment, Somryst is not available at the present time. The business model, I think, for what they're doing is somewhat different. The Sleepio is available for patients 18 and over, and there are codes, G codes, which allow clinicians to be reimbursed for recommending the treatment and supervising it. But people do all the treatment on their own at home. So if we're trying a way to level the playing field in order to deliver guideline care, we need to up the provision of effective cognitive behavioral therapy. So that's been the main problem. We don't have overprescribing. Well, we may have, but that's not the core problem. The core problem is massive underprovision of alternatives. So the evidence-based care that we need to scale at population level is CBT. And we've approached this challenge incrementally by solving for the wrong problem. We've sometimes been doing important things, training more people. At Oxford, we train people, or have over the last 8 years, we've trained people from 50 countries using our Oxford resources to help people learn about sleep medicine, about cognitive behavioral therapy in particular. But we need to do both things: train more people as generalists and specialists, and provide better evidence-based resources that are scalable. And in the case of CBT, the primary reason, and I think what you're going to see going forward is a great expansion and so industrial scale expansion in cognitive behavioral therapy that enables it to be provided with all the same checks and balances that you'd expect for any treatment entering a system. We need to obviously influence and adopt how healthcare procurement works for CBT to be feasible, because you've got products, but how do you get them into practice? And successful scaling requires the development and execution of an accountable industry. So I think going forward, these are some key alliances that I think are going to transform insomnia services, not just CBT services. First of all, we have historically had sleep research and circadian research. We've had sleep medicine and we've had circadian therapeutics to some extent. But it's mostly in the sleep area that the therapeutics have been developed. And the circadian area has been more the area of science. I think what we're going to see going forward is a much closer alliance between sleep scientists and circadian scientists and the development of sleep and circadian medicine. So that's going to be really an important alliance going forward. And we're going to see that approach delivering better care, both at specialist services level, like sleep centres, university hospitals or whatever, and in the mainstream. And I think that'll be enabled by diversified training. You know, that sleep has often had a bit of a challenge because it sits on a lateral in healthcare. It's not really owned by any a medical profession or discipline. It's not been championed, or if it has been, it's championed just within the specific disorder, like sleep apnea and respiratory medicine. And sleep medicine's often sat on that lateral because sleep is relevant everywhere in medicine and therapeutics. But I think a good thing about that is that the diversified training approach means that we can expect everyone should know something about sleep. Everyone should know something about the timing of sleep. Everyone should know the basics of how you manage insomnia difficulty, for example. And of course, you need people with greater expertise. And I think where cognitive behavioral therapeutics is concerned, there needs to be a greater partnering of psychology with engineering, particularly software engineering, facilitated by a thriving and accountable digital therapeutics industry. After all, healthcare systems don't make anything at all. They don't make any products. From a physician's point of view, you would have no treatments of any kind and no equipment to deliver treatments. As a surgeon, you'd have no theatre and you'd have no operating instruments, because all of that is made by accountable industries, drugs, not least pharmacotherapy. I think what we need is an accountable therapeutics industry that's going to make these digital mental health treatments and provide them to a specialist and diversified mainstream teams who are able then to deliver a cognitive behavioral therapeutics at scale. I think that's something that's going to make a big, big difference going forward. So just to finish up, I said earlier on, there's always been two approaches to managing insomnia. There's always been sleep hygiene, and this term that was developed by Peter Howrey back in the 70s, it was a term actually he came to loathe a little bit later in his life, because it never it took on a life that he didn't intend it to. You know, it became a kind of ministry of no fun list, right? Don't drink, don't take too much caffeine, etc., etc. It became very prescriptive about the bedroom environment and about your lifestyle. Peter's intention was, of all the things that might not be good hygiene factors around your sleep, find the one thing that is affecting you, rather than here's a list of things and people say, well, I've done all that. None of that's relevant for me. But there's always been sleep hygiene or head hygiene. So here we have something cited in the Glasgow Herald, reported in the British Medical Journal. Soap your head with the ordinary yellow soap. Rub it into the roots of the hair until your head is just lather all over. Tie it up in a napkin. Go to bed and wash it out in the morning. Do this for a fortnight. So there you go. Or take no tea after 6 p.m. There we are, caffeine. I did this and I've never been troubled with sleeplessness since. And this historical piece from 1894, amongst others, reviewed by the late Jim Horn, and he says that the editorial wisely ends with the comment, we can't help thinking that some of sleepless readers would prefer the disease to the cure. But if any should like to try it, may we advise that they should first at any rate follow that part of the advice which relates to tea and leave the soap part as a last resource. There's Insomnia Victorian style. There's always been sleep hygiene. And, you know, one of the things I've been involved with recently is thinking about how can we refresh this. And I want to show you a brief animation, which lasts about 2.5 minutes, which I hope you find interesting. It's on the 5 principles of good sleep health. There's resources that go along with this, and I'm grateful to Sacha Baron Cohen for voicing the animation.
Lately, a lot of us have become really fixated on sleep. We time it, we track it, in the hope that we can eventually master it. Good sleep is really essential to the functioning of every human mind and body. But if you focus on the data and the details of your sleep, it's really unlikely to improve it. In fact, it could have the opposite effect. After all, sleep done right isn't really something that we do at all. It's something we simply let happen. So instead of setting really rigid rules and aiming for perfection, try applying these 5 principles of good sleep health wherever you are in the world or in life. First, value your sleep. Remember, it heals us, balances our emotions, keeps us energized, and supports our cognitive function. We can't live without it, so we've got to see it as the life-giving treatment that it is and prioritize it. So just as we make time for food when we're really hungry, make time for the sleep that you need. And that means don't allow other less important activities to steal your sleeping time. Well, at least not every night. Next, we need to really personalize it. We wouldn't expect everyone to walk around in the same size shoe or slipper. So understand that everyone's sleep needs are also different. So try to experiment with your sleep to get it right. Maybe try going to bed earlier or later. Maybe spend less or more time in bed. You need to discover the sleep pattern that feels most comfortable for you. Next up, take steps to protect your sleep. So go beyond the usual recommended tweaks to your routine. Try to develop a deep understanding of how things like stress and mental activity could be affecting you and why it's useful to put the day to rest before you go to bed. But most importantly of all, you've got to trust sleep. So good sleepers don't try to sleep. They just trust that sleep will come. Trusting can be really hard when you've struggled to sleep before. But following the 5 principles of good sleep health really is the best way to unlock a better night's sleep. And with it, the benefits of nature's most powerful medicine. You can find more information just here. I think it's over here, or maybe it's up here. They didn't tell me. Look around this page and you'll probably find the link to the information. Just trust me, it'll be here.
So I hope you found that a bit of fun and helpful. This is a free to use resource that we developed in Oxford, and we did it in collaboration with a charity in the UK called the Sleep Charity. And on this website, there's other resources which you can use, which give you the background to it. There's also a paper in the Journal of Sleep Research on it. And it's had quite a lot of traction in the UK. Back when it was launched in January, I ended up on BBC Breakfast, fame at last. So I'm really grateful to you for your interest in sleep. I've spent my career working in this area, and it's been really, really rewarding to do so because sleep touches everything. And when people can't sleep, it touches everything in ways that affect them badly, particularly when insomnia becomes chronic. So I hope this little introduction, perhaps, to rethinking chronic insomnia care in the 21st century is helpful to you in your practice. And thank you for all the work you do with people with sleep disorders.
Thank you so much, Dr. Espie, for this very insightful and exemplary overview.